All right. Make sure my microphone is good. All right, so this structure that we see here in the hand, it's going to be familiar when we get to the foot, which is a lot more exciting than the hand. And when I joke around when I say the hand's not exciting, if you didn't have function of your hand or you lost use of your upper extremity, you'd be screwed. Particularly if it was your dominant arm. It's just that it's more impairing when you lose the ability to put weight through your leg. So in your clinical career, you'll come across many patients that have different weight bearing statuses. They'll have like toe touch weight bearing or non weight bearing. And you've probably, if you haven't had it yet in your ortho class, you'll come across scenarios where you have elderly patients that fall and they fracture their hip, and you either heard stories or have known someone or tragically have had someone in your life that have succumbed to their fall, whereas a hip fracture led to their demise, to their death. And the reason why this is that people, when they fracture their hip, usually have a non-weight bearing status. They're not allowed to put weight on their legs, typically don't have the upper body strength to use an assisted device to offload, and then they're bedridden for a while and they're not moving as well. They get infection, they get pneumonia, and they usually succumb to their injuries. So when you fracture your wrist or someone's not non-weight bearing on their arm, they're still up and mobile. So it's not as limiting. You can't do as many things, right? You can't brush your teeth or button your shirt or wipe your butt or whatever hygiene you need to do. So it's more difficult, but it doesn't necessarily lead to death like a weight bearing status in the hip or a foot or ankle would. But what we'll find when we look at the joint structure of the wrist, it has a somewhat similar structure to that of the foot. The main difference being that the foot is load bearing, where the hand is not. And we actually, throughout the lectures, throughout shoulder, elbow, shoulder complex, and now in the wrist, we have a lot of mobility in our upper extremity. The reason why we have that, not the reason why we have that mobility is because we're not load bearing through that. So we're bipedal, we're on our 2 feet, and it allowed us to whether evolve or adapt or design to be able to manipulate our environments with our hands. And so we've been able to use tools, create music, art, and so forth because we don't have that load bearing responsibility. When we look at the wrist, you have the radius and the ulna, which we already looked about when we looked at the elbow. And we said that at the proximal end of the radius, has a very little or minimal contribution to the elbow joint, and the majority of the forearm proximal is the ulna that makes up the elbow. Well, that relationship is reversed when we get down to the wrist. We see that the radius actually makes the majority of the contact at the radial carpal joint, and the ulna, although there, is more of a supporting aspect. What you want to see here is that you have three lines, and I really like that this image does this. Is you have your bones of your forearm, so you have your radius and your ulna. You have your bones of your wrist, which are carpals, and then you have your metacarpals and your phalanges, so your base bulk of your hand and your fingers. You have three distinct joints here. You have your radial carpal joint, which is going to get all the attention for flexion, extension, ulnar deviation, radial deviation. But this motion is coupled with the mid-carpal joint. And then when you make any kind of movement with your hand, and we'll get further into that when we look at the hand next week, you have the carpal metacarpal joint. But really, the flexion and extension and the ab and abduction that's happening is a combination of both the mid-carpal joint and the radial carpal joint. So you have two tiers, and we'll see this again when we look at the foot. We'll look at you'll have like the subtalar joint, mid-tarsal joint, and the tarsal metatarsal joint. And through that, these three main joints, you're able to get all that flexibility and different crazy positions you can move your hand into. What you'll see here are the primary movements. So you have wrist to neutral. And wrist neutral, let me switch back to my screen here. Just to blow me up here. So if you make a knife hand, which is considered neutral, but a real neutral, you can see that my hand isn't flat. Like if I had a book right here and I laid my hand flat, that wouldn't be wrist neutral. That would actually be a little bit of flexion coming out of that. And if you just go ahead, give me like a salute right here. And if you make a fist, you'll see that if you make a fist, you actually go into a little bit of wrist extension while you do that. And that we'll talk about that in the muscles in a little bit, but that has to do with like length tension relationships. But a neutral wrist is somewhat of a relaxed wrist, and you would favor slight extension. So the plane between the forearm and the hand isn't straight up like that. It actually does yield a little bit. So when you bend your hand to go here, you're actually flexing the wrist a little bit. So this is considered wrist neutral. particularly when you're looking at exercise, right? If someone's holding a bar, marker, hold on. Someone's holding a bar, so you have like I got a dollar out here, but if you go and you're holding a bar here, you're balanced here through the forearm, and you're actually in a little bit of wrist extension to keep that balance, with or without a grip. So this wrist neutral is not straight in this plane, but it actually is slightly extended. And that's going to be the most comfortable position patients get into, particularly if you're having him hold like a dumbbell, or you're having him hold like a stirrup for a cable thing, or even holding an elastic band. If they have to grip, they're going to go into a little bit of extension for that. We'll play around with your force relationships when we look at the musculature. And then you have ulnar deviation and radial deviation. So are you deviating toward the radius, the thumb side, or are you deviating towards the ulna or the ulnar side, the pinky side? There's your radial. And if you do that, you can see that you have significantly more ulnar deviation than you do radial deviation. Okay. And you have probably equal amounts of flexion, depending upon what kind of work you do. If you do a lot of like manual therapy or a lot of lifting, you might have more tightness in the forearms, and you'll be tighter in flexion than you are in extension, but you should be equal in both of those. I don't like that the text uses the word hyperextension, so let me go over here. Switch back. You know, this hyperextension in my mind means that there's excessive extension. So that means you went beyond the normal physiological region of the joint, and you ruptured some ligaments or anything. But extension or hyperextension, but this is saying going from a flex position to an extended position, or this case neutral. You can see it comes out. You can see this line. Where's my thing? You can see the line's not perfectly straight, but it does come out just a little bit. So it's kind of making that angle. And then from neutral beyond, that really is just still extension, but that's what the textbook does. Just keep in mind that there are different perspectives when you look at whether you're looking at the spine, whether you're looking at wherever you're looking at. If neutral or anatomical position is neutral or zero, anything beyond that sometimes is referred to as hyperextension. But it's also extension as well. So both are correct answers. I think extension is more appropriate. So then we go into, that's the joint motions. Let me flip over to the Newman textbook. Let's go to the top. I really like this textbook. It has better. Okay. Oops, that's right, it doesn't do that. All right, so here's your wrist here. You can see the carpals. You can see the, oh, it's a little slow. Give it a second. You can see the radius. You can see the large contact surface. It's haywire here. You can see the large contact surface that the radius makes at the distal end and the smaller of the ulna. You can see the scaphoid and the lunate are the two carpals, and these are the 7 carpal bones that make up the wrist. You have your proximal and you have your distal. Right here is that mid-carpal joint, and then here's your carpal, metacarpal phalange, or metacarpal carpal joint. But this is the large contact surface here between the radius and the ulna. There's another slide that shows, but you can see the scaphoid lunate. This scaphoid bone, if someone ever like falls and they have an outstretched hand, so let's say they slip on the ice and they put their hand out and they land on the surface that way, usually in what now I would call a hyperextension, where they've gone beyond the physiological joint capacity, so they were extended, hyperextension, you tend to have fractures through one of these 3 bones. Lunate fractures and capitate fractures are usually pretty good recovery. Scaphoid fractures tend to have poor recovery because of the poor blood supply, and it's because it's kind of housed in all this connective tissue. Here are the bones. So this is a cool view. You can kind of see now, this is where the radius and the ulna would be. So the radius is kind of here covering, let's do this, oops. The radius would be connecting to these surfaces here, and the ulna would be barely touching. And you can see that really the lunate and the scaphoid are the primary bones that make up the wrist joint that we're looking at, the radial carpal joint. There's another image. We'll look at the carpal tunnel a little bit, but this is the MRI image that you can see of the carpal or the scaphoid injuries. So here's your radius right here. Here's your ulna. There's your lunate. There's your scaphoid, and you can see how it is. You can see the darkened signal there. So there's some space. It's fractured, and then this is of some degeneration of that bone. But scaphoid fractures usually are not. Usually not well recovered. They take some more time. Here's a cross section through a planar cross section. You can kind of see the contact surfaces and some of the little ligaments that are there. Technically, all of the interactions between the carpal bones are joints. So the hamate and the triquetrum, the capitate, the scaphoid, all these are articulations. And so technically these are joints, but we tend to look at these as functional joints. Just like if you look at the cervical spine, C5, C4, C3, yes, those are all individual articulations, but we kind of look at them as a functional group. Same thing here. You have that carpal metacarpal, radial carpal joint, metacarpal joint, and that carpal metacarpal joint. So kind of a cool view. You can see that reflected out. So here's your hand, there's your carpals, there's the space between the metacarpal joint, and then there's the radial carpal joint. So you have these ligamentous structures that come and form and stabilize through the wrist. But what these structures start to make is what we refer to as the carpal tunnel, and you can kind of see that reflected out a little bit. And what the carpal tunnel is, you can see like this hollowed out area where the bones are at. And let me see here, image showing flexion, extension, radial deviation. All right, let me hold here and go back to the other book. So we're going back to the clinical kinesiology. So here are those palmar ligaments. So if this is looking at your palmar part of your hand, so the inside of your hand, here's your radius ulna, and you have a set of ligamentous structures that cover over, and there should be. Let's just do this. So here are your carpal bones. Here's your thenar and hypothenar eminence here, and then you have that transverse carpal ligament and that other ligamentous structure that I showed you. And then what you have here is you have your nerve structure, and then you have all of the tendinous slips that are coming from the forearm flexure, the flexor digitorum superficialis and the profundus. And these muscles are the extrinsic muscles of the hand. So you have the bulk of your wrist flexors and finger flexors. Your wrist flexors cross just over, and they're connecting right onto the carpals. But a lot of the finger flexors and extensors, but particularly the flexors, both at the proximal and distal phalanges, those tendons are coming down the fingers through the hands, and those muscles are actually originating up here with the origination up on the medial condyle. And so from here, the muscle bellies are about 2/3 of the forearm, and then all of those tendons are shooting down into this space. So what ends up happening sometimes is you can either have like a vascular inflammation, you can have a tendinitis, and this starts to swell, and then that puts pressure onto the other nerves. You start to get friction and more pressure, and it's just a downward spiral. And sometimes what they'll do is they'll do like a carpal tunnel release, where they come in and they snip this ligament to kind of off pressure this to relieve some pressure here. And typically this is a one and done type procedure. They come in, they snip it, they suture it up, and usually immediate relief. And it just takes some time for that tendon to restore. The problem with the carpal tunnel procedures is that they never address the underlying reason of what was causing abnormal forces or loads into that tendon in the first place. And since this nerve is coming up from the cervical spine, from the brachial plexus, a lot of times you can have shoulder or neck instabilities that are creating a domino effect, that are creating abnormal forces or abnormal work through those tendons and causing that issue. So unless you actually address that upper issue, you will have a repeat or sometimes have a bilateral issue where you started out in your right hand and then it moved over to your left. Let me see if I get another image of the carpal tunnel that kind of shows the. Yeah, I like this image here. You can kind of see the ulnar nerve and you can see the different tendons that are coming through. You can see the cross section of the bones. You can see that retinaculum and the tendinous structures that are, or the ligamentous structures that are covering over that. This is the actual procedure, and they literally just cut it. They just open the skin up, they make an incision, they cut that tendon, release it, and then they sew everything back up, and everything heals on its own, and they kind of offer some space. So it's a pretty straightforward orthopedic surgery, but it severe. I'm surprised the textbook. I thought there was more in it. I thought the textbook would talk more about the carpal tunnel effect. See if this textbook talks about it. This real quick, just as this is that compressive force. This is showing when you fall like an outstretched hand, that scaphoid fracture. So you have the force of the radius kind of hitting into the scaphoid. This scapholunate ligament ruptures, and so then this is separate from the scaphoid, and this tends to deteriorate because it doesn't have good blood supply. So this is part of those scaphoid fracture. And I think there's a, okay, yeah. Neither of these books looking at the carpal tunnel, huh? Oh well. Okay. All right, so a lot of the muscles that are that control the wrist. So you look at wrist extension, wrist flexion. These are all the bulk of the muscles are in the forearms, with their origination either at the medial epicondyle of the humerus or the lateral epicondyle of the humerus. And there actually is a good. So I really like this image in the textbook. It kind of shows that you have your general extensors and you have your general flexors, then you have your radial deviators and your ulnar deviators, and you're not quite in these cardinal planes. So if something's named radialis, it's most likely going to be a radial deviator, and if it's named ulnaris, it's going to be an ulnar deviator. If it says extensor, it's going to be an extensor. If it says flexor, it's going to be a flexor. But flexor carpi radialis, none of these muscles do pure flexion by themselves. They do flexion and a little bit of radial deviation. These do extension and a little bit of radial deviation. So when you're doing radial deviation, so if I'm bringing my thumb up, I'm using my extensor carpi radialis and my my flexor carpi radialis. So you can use your flexor and your extensors to do radial deviation on that radial side. So in that case, they're working as synergists or agonists with each other. But then if I'm going into extension or flexion, now they're working as antagonists or opposite, reciprocal inhibition aspect. So just keep in mind that if you're looking at trying to analyze function, so if someone might have wrist pain and you say, okay, go, you just kind of have them go through all four movements, flexion, extension, and sometimes that will, like if you even if you kind of grab your forearm and you go into ulnar deviation, you can feel all the muscles on the ulnar side, both your flexors and extensors firing, and you'll feel the radial side relax. If you do that same thing, keep your hand in the same position, you go into wrist flexion, you'll feel both the flexor carpi radialis and the flexor carpi ulnaris contract, and you'll feel these guys relax or go under tension because they're under slack. So just keep in mind that there's overlap in terms of the muscle participation. You don't have true extension, you don't have true flexion, you don't have true radial or ulnar deviation. The Newman textbook also shows these force relationships right there. So it kind of has this grid system, and you can see the not only are you seeing the wrist muscles, but you're seeing some of the extrinsic hand muscles as well, and you can see where their force of line of pull would be. So here's your anterior, here's your posterior. So this is you laying your hand flat. looking through it, and you kind of see your angle, your perspective, the cross section there, and you can see who is going to be more flexors versus ulnar deviators, extensors versus radial deviators, and the further they are away from this line, the bigger moment arm they have, the more involved they are. So your extensor digitorum. So when you look at your wrist extension capabilities, you have your extensor carpi ulnaris. Your strongest wrist extensor doesn't even attach at the wrist; it goes right on by, and the muscle that does this, that extends your fingers, is actually your strongest wrist extensor. When you look at your strongest wrist flexor, it's neither the flexor carpi ulnaris or flexor carpi radialis. It's actually the flexor digitorum muscles, both the flexor digitorum superficialis and flexor digitorum profundus, and those are the muscles that do this and do this. So like distal flexion here or there, but since the tendon slip goes all the way down through the carpal tunnel, it is one of your most powerful wrist flexors as well, and it's because of the distance where it's at from the axis of rotation. So just keep in mind that although we're looking at the wrist, and that's why my videos, the lectures that I posted, look at the wrist and the hand in conjunction, because it's very hard to just isolate just wrist and not include the muscles of the fingers or the hands as well. But the textbook separates it out. So we'll look at it this week just as a quick introduction to the wrist, and then we'll look at it in more detail with the extrinsic hand muscles as well. So at the beginning of the lecture, I kind of talked about that neutral position, and you can see that when you're grabbing anytime you're grasping or squeezing, you can see that the body tends to go in a little bit of wrist extension. And if you remember the video from the very first exam where we looked at musculature and we were talking about passive insufficiency and active insufficiency, and if you recall, we're strongest in mid-range position. So in a really shortened position. So if you wanted to maximally shorten your wrist flexors, and we said that the strongest wrist flexors and the strongest wrist extensors also involved in finger flexion and extension as well. So if you wanted to maximally shorten them, meaning putting them in the weakest position possible, you would maximally flex at the wrist and you would maximally flex at the hand. And if you try to do that right now, if you just stay neutral and make a fist, squeeze as hard as you can, you'll feel like you have pretty good grip. Then what I want you to do is I want you to flex at the wrist fully, and it doesn't have to be fully, just keep it there, and now try to flex and see what happens. You're like a little sissy hand now, you can't grip anything, right? So if you wanted to, now go back in this position, and if you do this, and your hand won't do it so much, but if you do, we'll do this when we get to the foot and the toes, you'll start cramping because you're getting these mixed signals. You're sending signal to the nerve, to the muscles, and they can't contract because they are, all those sarcomeres, all the filaments are all overlapped and they're jammed up, and then you're trying to generate force from there, and the body's telling you to piss off. It's not doing it. So what happens then is that if you stay just neutral and try to squeeze, you'll feel that you're a little bit stronger. And actually your strongest position, because if you're shortening here at the fingers as you're gripping down, you're shortening here. If the body wanted to stay in mid-range and maximize its grip strength, you would actually go into a little bit of extension. So if you don't even think about it and just grip as hard as you can, you'll notice that even if you try to keep your hand straight, your body naturally wants to go in a little bit of wrist extension as you are trying to squeeze as hard as you can. And what it's doing is it's keeping the muscles in mid-range. As it's shortening here at the fingers, it's lengthening here at the wrist to keep it right in that happy medium, right at that sweet spot. Same thing for extension. If you come all the way into extension and you try to like extend out, ain't gonna happen, right? But if you figure out where you're gonna be the strongest in extension, you're gonna favor a little bit of wrist flexion as you go into extension. So kind of neat. It's a really cool application. And so again, then if you're looking to maximize your grip strength, let's say you're pulling from a deadlift or you're having a client do something, or you're always, you'll see people try to bench press and they got the bar and they're trying to grab here, and they're trying to keep their wrist as straight as possible. And that's like the dumbest thing you can do. Not only that, gravity is now going to pull that bar out and you're going to have an accident that way, but here you're actually balanced because now your load line is going right through the joint, and you're actually maximally gripped here through that load because as you're squeezing as hard as you can, your body's naturally going into a little bit of extension. And so that's what you're seeing in this image here, is you're seeing as I grip, as these finger flexors are shortening through the interphalangeal joints, it is lengthening through the radial carpal joints. So it's lengthening here, so you're getting a net change, so you're able to maintain that extension or that maximal force production. And this is charting. You can see, like, if we were to do, so this is a hand dynamometer, and this measures how much tension, basically how much you can squeeze. And so if you were to do this and do it, you can see in this picture here, she's doing it in flexion, and in this one, she's doing it in a neutral position. If you chart it, you'll find that as you felt just without having to measure it objectively, that in the fully flexed wrist position and finger flex position, you had virtually no force. If I held this pencil here and had you do that, I can come and pull that. Even if I said I'm going to give you $1 million, you're not going to do it, right? What you're going to want to do is you're going to favor that happy medium. And you can see that on the far right now over here, if I go even full into extension and then try to contract, now I'm going too far into a lengthened position and I'm coming out of mid-range a little bit. So I am stronger fully extended and flexing than I am fully flexing, but really my strongest is right in that mid-range where I can stay right at that sweet spot there. If that's not making any sense to you, I would definitely go back and review the passive and active insufficiency video from the musculature, looking at length tension relationships and the overlap that exists with muscle force production. Just remember, I have all you guys muted, and I can't see my my chat. So if you have a question, feel free to interrupt, but you have to unmute yourself and say, "Hey, Jonathan." Okay, so now we look at some of the muscles here, and here's your medial epicondyle right here. And here's your lateral epicondyle. So this is on the humerus. And the medial epicondyle is the common flexor attachment site. And the lateral epicondyle is the common extensor site. And you'll have these conditions clinically that are medial epicondylitis or lateral epicondylitis, sometimes called golfer's elbow or tennis elbow. And what can happen because of the repetitive stresses that happen through these tendons, you can start to get some inflammation and irritation there. And it can be really tender to the touch. And you don't have to play golf to get golfer's elbow, and you can get golfer's elbow if you play tennis, and you can get tennis elbow if you play golf. So it just happens to be these common sports that these pop up in. But any type of repetitive stress can put extra load through that. Now, either the proximal tendon can get irritated or the distal tendon, and this is where you'll start to get more of that carpal tunnel type aspect. But if you're getting carpal tunnel, there's more stuff going on in this aspect. But this is relatively common to have these conditions, and they never. Sometimes they go away. Sometimes they never fully go away. Even if you rest, there's typically, a long story short, there's typically a biomechanical aspect that's happening, and there's only so many joints here that can be caused in the kinetic chain. So typically, when you see medial or lateral epicondylitis, you're sometimes looking up the chain to see, where is my shoulder unstable at? Is the shoulder unstable with the scapula? Is the scapula unstable with the thoracic spine? Is that coming from the cervical spine? And so just keep in mind that just because you have complaints or symptoms here in either of the elbow, that it doesn't have to be local there. That could be where the local inflammation is, but that could be sourced from some other thing that's happening. And I would argue, I don't have the hard data to support it. I don't know from my clinical practice that if I see carpal tunnel or medial or lateral epicondylitis, I'm looking up the chain before I look down the chain. This is your palmaris longus, and I don't remember the percentage, but I think there's a certain percentage of the population that doesn't have this tendon. And if you let's see if you can see that line right there. If you kind of make a claw hand and go into a little bit of wrist flexion and flex, and you can see, so kind of look at your palm and see if you have that little protrusion, like that little, then you have the palmaris longus. If you don't have it, then it's just part of your flexor carpi radialis. That's just trivia night if you want to win at trivia. So this is what I was looking for earlier. Here's that transverse carpal ligament. This is the ligament that they cut for the carpal tunnel type aspects. And you can see the palmaris longus kind of coming into that a little bit, but then you have your all of the flexor digitorum profundus, flexor digitorum superficialis, extensor digitorum, or not, I'm sorry, not extensor digitorum, but the other ones coming through that, that transverse carpal ligament. So this is just showing active ulnar and radial deviation. The swinging a hammer is the most typical example for that radial deviation and ulnar deviation. So you can see the radial extensors and the radial flexors coming up, overcoming gravity, and then you're accelerating. So if you remember from the previous exam where we looked at eccentric on the way down, you're accelerating this. So if you come up, you're cocking up to bring the hammer up, but then you're trying to quickly come down. This wouldn't be an eccentric contraction. This would be a concentric contraction, and you'd be contracting the ulnar muscles now, the flexor, the ulnar flexors and ulnar extensors into ulnar deviation. And you see that here. There's the ulnars contracting, extensor carpi ulnaris, flexor carpi ulnaris, and then the extensor carpi radialis and flexor carpi radialis to pull back. And let me see, hopefully it's still there. Yep. And it's going back to this slide here that your extensors aren't purely extensors, they're also radial deviators as well. So again, this is where if you were going to get some test questions or you were going to look at some, even on like your licensing exam, they're going to tease out your ability to understand that the extensors aren't just extensors, but they're also the radial deviators. And that the extensors and flexors can be working as agonist and not necessarily antagonist relationships. So realize that in extension and flexion, they're going to be working as antagonist relationships, but in ulnar deviation and radial deviation, your flexors and extensors, and that's where sometimes students get confused is they'll say, oh, okay, let's pick one of these. Which of these muscles are not agonists or which of these muscles are antagonists? It's very easy to kind of fall for the trap and say, oh, an extensor and flexor, they're opposite. That's got to be the answer. Well, that's not true or ulnar deviation. The extensor work. I think that's it for that one. And oh yeah, this one I want to show you guys too. Let's go back up. So I started the lecture with this. Let's go here. So remember, we have the mediocarpal joint, the midcarpal joint, and the carpal metacarpal joint. So you really have three joints that make up the majority of the flexion, extension, and ulnar and radial deviation. So you're not truly just getting radial carpal joint, you're getting a little bit of this. And this image here, oops, it kind of shows that here's the radial carpal joint, but you're also getting mid-carpal joint motion. And so they're working combined. So it's a combined of three joints that are working to get wrist extension and three joints to get wrist flexion. I think you're doing three joints to get ulnar deviation and radial deviation. So although you separate them out, it's not just the radial carpal joint that's moving, it's also the interaction of these joints. Although there is an articulation there, an articulation there, articulation there. We don't look at those particular, we just look at them as a bulk of the mid-carpal joint. So where this would come into play is if you're doing like manual therapy for wrist, if someone's wrist or ankle or something, you're looking at not just the primary joint that's labeled in the joint motion, so wrist extension. So the wrist is technically the radial carpal joint, but it could also be the mid-carpal joint or the carpal metacarpal joint that's also the issue. So again, I guess the moral of the story today is more look beyond just the actual source. If there's a problem or if there's an issue, that you can either look at multiple things within the joint or look up and down the kinetic chain. And I think it's pretty straightforward. There's really not much complexity. The elbow, and that's why I was quasi joking at the beginning. It's like the elbow and wrist really aren't that exciting because there's just not much complexity to it. Like if you compare it to the shoulder, right, with the all the musculature happening and all the things, all the moving parts, like the shoulder girdle and the glenohumeral joint, there's a lot of stuff to kind of wrap your brain around. But I think that's the most difficult thing within this unit, the upper body, is the shoulder complex, although pretty straightforward once you wrap a brain around it. Then you move down to the elbow and there's not much going on. You get into the wrist, there's really not much going on. And then when we get into the hand, there is a lot going on because of all the things that you can do with the hand. That's all I have for. That's all I have for the to go over the chapter. I'll entertain any questions if you guys have any questions.
I have a few questions. So whenever we're doing pronation, I know that the radius it's more so connected with the metacarpals. Are the metacarpals rotating as well? And the
See if
ulna
I
just
have
staying stationary?
I think I. Pronation. You're getting this all here. There's maximal. So here's your wrist. Let's do this like this. Pronating super. The at the elbow joint here, you get this longitudinal spinning, this rotation. Because of its structural connection there, because of that olecranon process and the trochlear notch there, there's no movement that's happening there. I mean, this is pretty bony, pretty stable. So what happens then is you look down at the distal end of the wrist, and when you look at the distal end of the wrist, you'll see that the proximal end, nothing really changes. You're just getting like spinning like through a long rod. At the distal end, it's overlap. So you're getting this in a supinated position. Those are parallel. In a neutral position, the bones are stacked, and in a pronated position, the bones actually cross. So if you look at the radius, in anatomy, the prime end, it's the lateral bone, and at the distal end, it's the medial bone, because this is the radius. That's the only move. It just kind of stays right where it's at, and the radius is moving over. We had looked at the attachment part, and we would see that the radius has the largest contact area there. So basically where goes, the wrist goes. And so as I rotate over, you'll see that it just comes with it. There's no twisting or movement here. It's all coming as one functional unit. Because the ulna does impact. So what the ulna is at the distal end, it's the radius is at the proximal end.
Okay. Also, for when you said the neutral position, is that because of the tendoesis?
If you relax your hand here and you go into, if you go into wrist flexion, I go into wrist extension, my fingers are going to go into flexion without me really even thinking about it. So go ahead and do that right now. If you go like from here, you'll see your wrist. When you go into wrist flexion, you get extension. Go into wrist extension, you're getting finger flexion. That's just the passive tone or within the connective tissue. So if you go into fully extended position and then you try to extend, you're going to have a hard time getting your fingers straight. The insufficiency of the wrist flexors are too tight, right? So if I just bend my wrist a little bit, I can get full extension on my finger. And if I'm here, I'm going to have a time getting flexion. But if I just extend a little bit, again, that's with the passive. So that's what this is. It's that passive tone and that tissue from the play on those biarticulate joints.
Okay. Also for the functional group, when you said that, is that pretty much like, let's say the scaphoid is messed up, that's going to be messing up the rest of the metacarpals? If one isn't sliding good, then
yeah, and they'll be in there, and you won't have a good articulate. That's why if you fall, like you tell patients all the time, and you can't tell them after the fact, but like a little word about if you fall, never put your hand up. That's usually ends up in putting your hand out to stop you from falling, unless you can just use your fingertips and not let your hand hit the ground. It's the compressive force this way that does it, not the low. You can touch the ground, you're good. But if you touch down, like, get out of it, bail.
All right. Also, for when it comes down to the carpal tunnel syndrome, you said it's pretty much like inflammation within the tendon. Instead of going to surgery, do you think there's any other way to be able to fix that other than we're checking the cervical, checking all that?
Yeah, if you're inflammation, what ends up happening, this is common with a lot of conditions, even rotator cuff strains and the medial lateral epicondylitis. You put the blinders on, and all you're doing is looking right there at the wrist. So, oh, look, the wrist, and they never look up the chain, right? If you talk to chiropractors, which are our sworn enemy apparently, they'll tell you that they have some of the best success rates with carpal tunnel, and they don't do anything at the wrist. All they're doing is stuff here at the neck, right? When I pull that, particularly if you have someone that has bilateral carpal tunnel, you could just, it's right-handed and use a mouse, and the way that their desk is set up, they're putting themselves in a weird position and they're doing like this weird finger stuff and forcing. Like, think about it. If this position and trying to contract here, I'm making that muscle do even more work. The muscle's doing the work. It's putting load through the tendon. The tendon doesn't have time to recuperate. It's inflamed, irritated, pissed off, and now I'm in this. So yeah, it could be just a local thing. Change your ergonomics, biomechanics, and you're good. But particularly, that's from the neck. No problem. Like nine times, I put money on it. It's coming from the neck. It's because of forward head posture and they're doing something here, and it's just a correction through there. So yes, if you can get to the source of the problem, but that's the answer for all your orthopedics, as strained Achilles or whatever it is. It can either be a chronic or it can be an acute thing. If it's an acute thing, it's just time. If it's a chronic thing, that's up to the practitioners to really look at it from a app and kind of free themselves from the blinders and say, okay, let's trace this through. Particularly if they've gone through a whole course of treatment and nothing's changed. Right? You can blame the patient all you want for not doing their exercise, but you're looking at
Okay. And also, just my final question. So when you're looking at the chain, where do you start? You said you start from like pretty much head to toe or head to wrist?
I'll start local.
Okay.
Hanging fruit, right? So if someone has knee pain, start at the knee, and then work one joint, and whether it's trying to trace pain or there's dysfunction. So like if I'm watching someone squat and I see like hip hike or knee diving in, I'll start there. Let's awareness thing. So let's start there, and that's kind of going back to what I said earlier. If things aren't progressing, there's only so blame the patient for not being compliant or not doing it or whatever. At some point, you have to take responsibility and say, this is not the issue. This is a symptom, and I keep on treating the symptom, and of course. So that's where your clinical skills will build with time, with your ability to kind of view things and understand things. And this is where your communication with the PT, especially in outpatient setting, they're seeing 12 to 14 patients a day. They're distracted, and you might get the same caseload, but to be able to observe happening and that back and.
All right. Thank you.
Those are great questions. Questions allow us to dig deeper into things. Who's got more? One question. I'm going to pick up. She might not even be there. Any questions at all? All right. So next week we'll look at the hand, the wrist a little bit from the musculature that goes from the condyles down through the carpal tunnel area, and the root. It will like elbow, because that kind of had the pronation. The wrist just looked at flexion, extension, and ulnar rotation. And we'll look at the from like grip strength and different types of mobility and some structures that are there. Questions. Have a great rest of the week, and it sounds like I've had a pretty good turnout, so this is an okay time for us to meet on